Welcome to the Deep Dive. We're the show that helps you navigate through all the noise to find the knowledge that really matters. Today, we're getting into something super common in hospitals and often pretty critical, dealing with dangerously low sodium levels, hyponatremia.
Yeah, it's a situation that, well, it puts doctors in a really difficult position because on one side, the low sodium itself, it can be incredibly harmful. We're talking, serious risks like seizures, permanent brain injury, even death if those levels get extremely low.
Absolutely. When you see serum sodium dipping below, say, 120 or maybe even under 125 if the patient has severe symptoms, well, that needs urgent action. But then, like you said, the danger isn't just the low sodium. The fix itself, the treatment, has its own risks if you're not careful.
That's right. That's the fear of ODS, osmotic demyelination syndrome. Thankfully, it's not common, but it's a truly awful type of brain injury. It can happen if the brain cells shrink too much too fast because the sodium level rises too quickly during the treatment.
Right. And for years now, the main focus in the clinical guidelines, the ones from around 2013, 2014 in the US and Europe, it's really been all about preventing that ODS, which led to these pretty strong recommendations for correcting sodium really slowly, like aiming for no more than maybe 8 or 10 milliequivalents per liter over a whole 24 hours.
Exactly. And those guidelines, well, they were based on the best evidence available then, but honestly, a lot of that evidence was considered kind of low quality, heavy reliance on expert opinion. And crucially, they focused almost entirely on the risk of fixing it too fast and didn't really weigh the potential downsides of fixing it too slowly.
Okay, and that sets us up perfectly for our deep dive today because we've got this major new piece of research, a systematic review and meta-analysis just published in JAMA Internal Medicine. And this pulls together data from, 16 different studies over the last decade, covering over 11,000 hospitalized adults with severe hyponatremia.
That's the one. And it specifically looked at how the speed of sodium correction lined up with actual patient outcomes. They compared what they called rapid correction, defined as 8 to 10 milliliter EQL or more increase in 24 hours against slower rates.
Okay, and this is where it gets really, really interesting because the findings seem to, they seem to push back hard against that old slower is always safer idea. What did the study actually show about things like, say, mortality?
Yeah, the finding was quite striking, actually. This new analysis suggests that the slower correction rates were actually linked to more deaths and longer hospital stays.
Wow. Okay, so the huge takeaway here, the thing that really flips the script, is that while everyone's been so worried about the rare risk of ODS from going too fast, the data now seems to strongly suggest there's a very real risk, and it's death from going too slow. Can you give us some numbers on that? What kind of difference are we talking about?
Yeah, sure. So the moderate certainty evidence from this review, it indicated that rapid correction was associated with significantly fewer deaths in the hospital compared to both slow and very slow correction. They estimated something like 32 fewer deaths per 1,000 patients compared to slow correction. And get this, a whopping 221 fewer deaths per 1,000 compared to very slow correction.
Those are really significant numbers. And it wasn't just deaths in the hospital, right? There was other stuff too.
No, exactly. The low certainty evidence also pointed towards rapid correction being linked with fewer deaths at the 30-day mark, and also a shorter hospital stay, over a day less compared to slow and more than 3 days less compared to very slow correction.
Okay, let's just pause and unpack this a bit. So we have the traditional fear, ODS, from correcting too quickly. And now this new evidence showing potential harm, including a higher risk of dying from correcting too slowly. What did this specific meta-analysis find about the risk of ODS itself when correction was faster?
So the main analysis didn't find a statistically significant increased risk of ODS with rapid correction compared to the slower rates.
Okay.
But, and this is really important, we have to acknowledge the study's own limitations here.
Hmm.
ODS is rare. It's a very rare event. So even large studies, like the ones pooled here, might not have enough statistical power to reliably detect changes in something so uncommon. And while the main analyses didn't show that significant link, some of their sensitivity analyses did hint at a higher frequency of ODS with faster correction. Though, interestingly, still without a clear sort of dose-response pattern across the different rapid rates.
Okay, so it's not like it's saying ODS risk is 0 with faster correction or
Mhm.
definitively ruling it out, but what it is showing, or rather what the studies included didn't show, was a statistically significant jump in ODS compared to slow correction, while at the same time showing this potential mortality benefit with faster correction.
Yeah,
That feels like a critical point when you're weighing the risks and benefits in the clinic.
it really is. Exactly. When you look at the available evidence now, especially thinking that, preventing death is a pretty central goal of medicine, the potential benefits tied to more rapid correction they seem to stack up favorably against the risks, particularly when you compare it to the known serious outcomes linked to just letting severe hyponatremia linger.
Right. And this kind of reinforces the idea that the hyponatremia itself is just inherently bad for you, doesn't it? Is it possible the higher mortality seen with slow correction is partly just because the patient spends more time in that dangerous low sodium state?
That's a very strong possibility, yes. And it's something the sources really emphasize. Hyponatremia isn't just a number on a lab report. It causes real problems. Cellular dysfunction, oxidative stress. It hits multiple organs. It's well established as an independent predictor of bad outcomes and death, especially in patients who are already sick with other things. And treating the hyponatremia effectively, that is associated with better outcomes independently. So leaving someone severely hyponatremic or correcting it at a crawl just means they're exposed to that harmful state for longer.
It sounds a bit like findings in some other electrolyte issues. I think I've seen studies on hypernatremia correction, high sodium, where faster correction was maybe linked to better survival, too. It sort of supports the idea that getting back to normal levels efficiently might be key for overall outcomes, rather than just hyper-focusing on avoiding one specific treatment complication.
Yes, I think that's a fair point. The consistency across different electrolyte imbalances does suggest the main harm often comes from the abnormal state itself, rather than purely the speed of fixing it within reason, of course. We're not talking about slamming sodium levels up uncontrollably.
Right, right. Controlled correction. Okay, so given this new evidence suggesting the old slow and steady might actually carry its own serious risks, how does this start to change how clinicians should be thinking about managing these patients, especially someone who comes in really sick with severe symptoms?
Well, for patients presenting with critical symptomatic hyponatremia, so think severe symptoms like seizures, really altered mental state, well, the guidance is clear. Intervene immediately and do things simultaneously. You don't have luxury of waiting around to figure out the exact underlying cause first.
Got it. You need to get that sodium up now to stop more brain damage.
Precisely. You'd immediately draw key labs, blood and urine osmolality, measuring the concentration, and sodium levels. You'd restrict any oral fluids right away, often NPO, nothing by mouth, is the safest bet initially. And avoid any IV fluids that can make things worse, like plain D5W, or even standard saline if the patient might have high ADH levels, making them retain water. And crucially, you start IV hypertonic therapy immediately.
And hypertonic therapy usually means using something concentrated, like 3% saline.
Yes, 3% sodium chloride or sometimes hypertonic sodium bicarbonate. Those are the standard tools. For example, giving a bolus, like a push of maybe 100 to 150 milliliters of 3% saline, that can often give you a quick bump of roughly 2 to 3 milliequivalents per liter in the serum sodium, which is usually enough to stop those severe life-threatening symptoms. The goal initially is just to raise the sodium by maybe 3 to 6 milliQL relatively quickly to get them out of immediate danger. Then you recheck the sodium level within an hour or two, see where you are.
Okay, but here's the crunch again. What about that risk of overcorrection? Especially in patients whose bodies might suddenly start correcting the sodium on their own once you start treatment. Like if the underlying cause turns out to be easily reversible.
Yes. This is exactly where strategies to actively control the correction rate become absolutely vital. And these are especially important for patients considered high risk for ODS. Who are those high-risk folks? Well, people with potentially reversible causes. Think severe dehydration, what we call hypovolemia, or adrenal insufficiency, maybe transient SIADH, that's syndrome of inappropriate antidiuretic hormone secretion, where the body makes too much ADH for a short time, maybe due to pain or nausea. Or even patients who are drinking massive amounts of water without enough salt, like in beer potomania or those tea and toast type diets.
And aren't there also certain patient groups known to be more susceptible, like premenopausal women or people with severe liver disease or malnutrition?
Correct. Absolutely. For those higher risk patients, or honestly, even as a proactive safety measure in many severe chronic cases, a technique called the DDAVP clamp is proving to be a really valuable strategy. What you do is administer DDAVP, that's desmopressin, a synthetic version of the antidiuretic hormone, ADH. Giving DDAVP effectively clamps the kidney's ability to excrete free water. It basically shuts down their water dumping mechanism. By doing that, you prevent the body from suddenly losing huge amounts of water on its own and causing an uncontrolled rapid rise in sodium, what we call autocorrection.
Ah, so you're basically taking artificial control of their water balance. You stop their kidneys from going rogue, so to speak.
Exactly. Once you've clamped their kidneys' water excretion, you then use calculated boluses, small specific amounts given periodically, not a continuous drip. Boluses of either hypertonic saline, hypertonic bicarbonate, or sometimes even free water like D5W to very precisely adjust their sodium level every few hours, maybe every 4 to 6 hours. You calculate how much fluid volume you need to give to achieve the sodium increase you want over that time period. You give the bolus, and then you recheck the sodium level.
Okay, so that's the DDAVP clamp-bolus strategy.
Yeah.
It sounds like it creates a much tighter feedback loop, much more control than just a continuous infusion.
It absolutely does. You decide the gradual path you want the sodium to follow. Maybe you're still aiming for a cautious 6 Mary EQL increase over 24 hours based on older thinking. Or perhaps, in light of this new evidence, you might aim for a slightly faster, but still controlled rate, maybe closer to that 8 or 10 mark. And then you use these periodic boluses to keep the patient on that planned trajectory. If their sodium drifts up a bit too fast between checks, you can actually give a small bolus of free water, D5W, to bring it back down slightly. If it's not rising quickly enough, you give another calculated bolus of the hypertonic solution. It allows for really precise, almost hour-by-hour adjustment and control, which is key for those high-risk situations.
That sounds more involved, maybe more labor-intensive than just setting up a drip. But it definitely offers a layer of safety against that dangerous, uncontrolled autocorrection that you might get with a continuous infusion, especially if the underlying cause suddenly reverses.
It absolutely does. And while there are equations that can help estimate the initial fluid needs and the effect of boluses, very close monitoring with frequent sodium checks, maybe every 2, 4, or 6 hours, depending on the situation, is just non-negotiable when you're using this technique.
Okay. What about situations where it's chronic SIADH, the kind that isn't easily reversible, maybe due to something permanent like a tumor or a brain injury?
Right. For chronic SIEDH, where the underlying cause isn't going away, the sources talk about oral urea, or sometimes a loop diuretic, combined with salt tablets as preferred long-term strategies. And of course, ongoing fluid restriction is usually part of it too. Oral urea is actually being used more and more, especially in Europe. It acts as a very controlled aquaretic. Basically, when you take urea by mouth, the kidneys excrete it, and because of osmosis, water follows it out. This leads to a predictable loss of free water and helps raise the sodium.
Right. I remember the sources mentioned you can even sort of calculate the expected sodium rise based on the patient's weight and how concentrated their urine is.
Exactly. It's a tailored approach to remote controlled water excretion. You do have to be a bit cautious using urea in patients with severe liver disease, though, because of the potential risk of hepatic encephalopathy.
Got it. And there was another interesting clinical pearl in there about correcting low potassium, wasn't there, when a patient has both hyponatremia and hypokalemia?
Yes, that's a really important one and a bit counterintuitive sometimes. Correcting a potassium deficit actually helps raise the serum sodium level.
Mm.
Think about it. Potassium is a major player in the concentration, the tonicity, inside cells, just like sodium is the main player outside cells. When someone's potassium is low, sodium often shifts into their cells to try and maintain electrical balance and tonicity. So by giving potassium back, repleting their potassium stores, you essentially encourage that sodium to shift back out of the cells and into the bloodstream. And that increases the measured serum sodium level. Correcting a significant potassium deficit, even just with oral potassium supplements, can definitely lead to a noticeable rise in serum sodium.
That's a really key detail for clinicians to keep in mind when they're managing patients with both of those electrolyte problems happening at once. Now, you mentioned earlier that the sources had some pretty strong warnings about a specific class of drugs, the vaptans.
Oh yeah, strongly cautioned against them, yes.
Mm.
The sources are quite clear that vaptans, drugs that block the aquaporin water channels in the kidneys, lead to essentially uncontrolled water excretion. And that's dangerous. They can cause a really rapid, unpredictable, sometimes massive loss of free water, which can easily cause the sodium to overshoot, potentially leading to severe hypernatremia, too high sodium, and significantly upping the risk of ODS. The very mechanism of how they work is considered inherently much riskier than the controlled approaches we've been talking about, like the DDAVP clamp.
It almost feels backwards, doesn't it? That some clinicians might feel more comfortable prescribing a Vaptan than using a carefully monitored, bolus administration of 3% saline.
The sources definitely echo that sentiment. They highlight that 3% saline, when used properly, with close monitoring and control strategies like the clamp-bolus method, is actually quite safe and effective. Vaptans, on the other hand, just have this unique potential for a runaway correction that's incredibly difficult to manage once it starts. It's why many international guidelines, like the European ones, recommend against their routine use for treating hyponatremia.
Okay, so where does this leave us? We've got this compelling new large-scale analysis suggesting that maybe faster correction within controlled limits might actually be better for overall survival, which really contrasts with that long-standing clinical focus on preventing the rare ODS by going extremely slow. Plus, you have the real-world challenge that in an emergency, you often don't know the exact cause of the hyponatremia right off the bat.
That practical challenge is a really key point one of the sources makes. If you can't immediately figure out the cause, the initial management for milder cases often still involves fluid restriction as a first step. But this new evidence fundamentally challenges the dogma that very slow correction is always the safest or most effective path overall, especially when you weigh it against the very direct and significant harms that come from prolonged, severe hyponatremia itself.
It really does feel like the clinical thinking is shifting, or at least needs to be reevaluated, moving maybe from only avoiding ODS at all costs towards a more balanced approach, balancing the risk of that rare complication against the very real and likely more common risks of the hyponatremia itself, and aiming for a controlled correction, perhaps more rapid than we used to think was okay, to minimize the total harm to the patient.
I think that's a very fair summary based on the evidence presented in these sources. The new data certainly tips the scales, yeah. It puts a bright spotlight back on the dangers of undertreatment or excessively slow treatment.
So, the big question then, the provocative thought to leave everyone with, what does this all mean for how we approach treating patients with severe hyponatremia moving forward? Given this new evidence suggesting potential harm from too slow correction and maybe a more favorable risk-benefit profile for faster rates than we previously assumed, how might this, or maybe how should this, influence future guidelines and day-to-day clinical decisions when managing this really common and complex electrolyte problem?